Okay, let's get straight into it. If you're prepping for exams, maybe the MSRA, or just need a really solid, high-yield grasp on a super common condition, this deep dive is definitely for you,
Absolutely. We're talking about Tinea today.
which most people probably know as ringworm.
Exactly. And it is, well, it's everywhere. It's a proper bread and butter diagnosis you'll encounter all the time.
Yeah.
And for exams, understanding the specifics, especially Tinea capitis, is absolutely crucial. Really high yield stuff.
Definitely need to know. And let's just quickly clear this up. Despite that name, ringworm, there are absolutely no worms involved.
Zero worms. We'll get to why it's called that.
Good. So our aim here is to really pull out the essential must-know facts about Tinea. Keep it clear, keep it focused.
Yep, we'll cover, what it is, the causes, risks, how it actually works pathologically.
What else it might look like, the differentials.
Who gets it, what you actually see clinically.
How we investigate it, how we treat it.
And then prognosis, complications, the whole picture, really.
Think of this as your kind of focused audio revision, the stuff that's most likely to pop up.
Okay, let's dive in.
So, starting right at the beginning, what is Tinea?
Okay, simply put, Tinea is a fungal infection, but it's a specific group of fungi. We call them dermatophytes.
Dermatophytes, got it. And they're a bit picky about where they set up shop.
They are. They specifically like keratin, so they infect tissues rich in keratin. That's your skin, your hair, and your nails.
Ah, okay, so they're essentially having a nibble on bits of you.
Huh. Well, that's one way to put it. Yeah, they metabolize keratin, break it down.
Okay. And the ringworm name, then? If it's fungal, where did that come from?
It's purely down to how one type often looks, a Tinea corporis, that's ringworm on the body. It can start as a red patch, spreads outwards, and sometimes the middle part starts to clear up.
Leaving a ring shape.
Exactly. So centuries ago, people thought it looked like a worm under the skin. It's a complete misnomer, but, it stuck.
Right, like calling jellyfish fish. Okay, so Tinea, fungal infection, dermatophytes, eats keratin in skin, hair, nails, and the specific name changes based on location.
Precisely. So Tinea capitis, that's the scalp. Tinea corporis, body ringworm. Tinea pedis, that's the feet, athlete's foot.
In Icarus?
Groin area, yeah, often called jock itch. Same group of fungi, just different locations. And Tinea capitis, the scalp one, that's really important to focus on, particularly for exams. It behaves a bit differently, especially in kids.
Okay, we'll definitely keep that one in mind. Let's talk causes, etiology. We know it's dermatophytes. Any specific types we should know?
Well, the main genera are Trichophyton, Microsporum, and Epidermophyton. You don't always need to know the exact species for initial treatment, but it can be relevant.
And what kind of environments do they just love?
Oh, they thrive in warm, moist environments. That's their ideal home.
Which makes you immediately think of places like...
Locker rooms, swimming pools, communal showers.
Yeah.
Anywhere damp where people might walk barefoot, hence athlete's foot.
Makes total sense. So how do these fungi actually spread? How do they get from one place or person to another?
Transmission is usually quite direct. Skin-to-skin contact is a big one, touching someone who has an active lesion.
Literally touching the ringworm patch.
Yes, or, and this is important, contact with an infected animal. Pets like cats and dogs can carry it, often Microsporum canis, and pass it to humans.
Good point. Don't forget the pets. What about objects?
Definitely. Contaminated objects or fomites. Think towels, clothes, hairbrushes, combs, hats. Sharing those is a very common way it spreads.
Right. Standard infection control advice there.
And then, as we said, those public damp places, gym floors, pool surrounds.
Okay, so direct contact, human or animal or indirect, through shared items and damp public areas. That leads nicely into risk factors. Who's more likely to get this?
Well, really, anyone can get Tinea, but yeah, certain things increase the risk. Close contact with someone infected, obviously.
Spending lots of time in those humid places.
Exactly. Or just having skin areas that tend to stay damp. And a really key one, particularly for exams, is having a compromised immune system.
Why is that so high yield?
Because finding Tinea in someone immunocompromised, it's not just about treating the rash. It signals you need to think about why their immunity is low. It could be a sign of something else going on.
Okay, that's a big so what point.
Well, yeah.
What else? Poor hygiene, sweating.
Yep, poor hygiene, excessive sweating. They create that ideal, warm, moist environment. Sharing personal items, we mentioned that towels, brushes.
Tight clothes or shoes, too.
Yes, especially things that trap heat and moisture. And even tiny cuts or scrapes on the skin can give the fungus an easy way in.
Makes sense, a break in the barrier.
Yeah.
Now, you mentioned specific risks for anthropophilic infections. It's human-to-human spread, right? particularly for Tinea capitis.
That's right. And these are super relevant for Tinea capitis. Age is a huge one. It's most common in prepubescent children.
Okay, so if you get an exam question, child with scalp issues.
Tinea capitis should shoot right to the top of your list. It's a classic association.
Got it. MSRA nugget locked in. Other factors.
Overcrowding, like in busy households or schools, increases close contact. Specific places like hairdressing salons or using shared combs and brushes among kids. These are practical ways it spreads.
Yeah.
Ethnicity is also mentioned as a factor, particularly noted in urban settings for Tinea capitis.
So you could almost build a picture. A young child, maybe from a crowded school, recently had a haircut, gets scalp issues. Tinea capitis risk factors are flashing.
Exactly right. Thinking about those factors really helps.
Let's get a bit more technical. Pathophysiology. How does it actually work when the fungus arrives?
It's fairly straightforward, actually. The dermatophyte lands on the skin, hair, or nail those keratin tissues. Then it starts to invade, using enzymes to break down the keratin, which it uses as food.
The keratin muncher's getting to work.
Pretty much. And your body doesn't like this invasion, so it mounts an inflammatory response. That's what causes the redness, the scaling, the itchiness you see clinically.
Right, so fungus arrives, eats keratin, body reacts with inflammation. Simple enough. And we know it spreads by contact. Okay. Now, this is crucial for diagnosis, differential diagnoses. What else can masquerade as tinea? Because lots of things cause red, scaly skin.
This is so important because if you misdiagnose it, treatment won't work, or you might miss something more serious. Tinea can look like a lot of other conditions.
Give us some key examples. What might look like Tinea capitis, for instance?
Okay, for patchy hair loss on the scalp, a big one is alopecia areata. The key difference usually is that alopecia areata causes smooth, non-scaly patches. Tinea capitis typically has scale and inflammation.
Scale versus no scale. Good differentiator. What else?
Other common ones, atopic dermatitis, eczema. It can sometimes show up as localized scaly patches, though often it's more widespread. Bacterial folliculitis, inflamed hair follicles, maybe with little pustules, can sometimes cause confusion.
Yeah, I can see that. Pustules might look similar.
Psoriasis is another big mimic. Plaque psoriasis usually has thicker, silvery scales and really well-defined edges, which can help distinguish it. Seborrheic dermatitis, especially on the scalp, causes scaling and redness, very easily confused with Tinea capitis.
Okay, lots of scaly scalp conditions. What about that slightly surprising one mentioned in the notes, secondary syphilis? How does that mimic tinea?
Yeah, it seems a bit out there, doesn't it? But the rash of secondary syphilis can be incredibly varied. Sometimes it's a maculopapular rash, can be scaly, often affects the trunk.
Okay.
And crucially, it sometimes involves the palms and soles. That's not typical for most tinea, apart from Tinea pedis, obviously. So if you see a widespread scaly rash, especially with palm sole involvement or other systemic symptoms, you have to think broader than just fungus.
Wow, okay. Scaly rash plus palm soles involvement. Consider syphilis. That's definitely one to remember.
It really is. Don't get tunnel vision. Another thing is an Eid reaction or autoexematization. This is interesting. It's not the fungus itself causing the rash everywhere.
What is that?
It's like an allergic reaction to the fungal infection somewhere else on the body. So you might have, say, athlete's foot, but then you get an itchy eczematous rash on your hands or trunk, even though there's no fungus there.
So your immune system is overreacting elsewhere because of the fungus somewhere specific. That sounds tricky to spot.
It can be. The main point is, while tinea often looks typical, keep these differentials in mind, especially if the picture isn't quite right or it's not responding to standard treatment.
Right. Always think broadly.
Yeah.
Let's zoom out again, epidemiology. How common is this, particularly in the UK? Who does it affect?
Well, UK numbers aren't really known, but globally it's incredibly common. Generally, it affects all ages, all genders.
But there are definite patterns for certain types.
Oh, absolutely. Tinea pedis athlete's foot is super common in the UK, particularly in adolescents and adults. That's probably the type you'll see most often in general practice.
Okay, athlete's foot is very common, especially adults.
But Tinea capitis, scalp ringworm, has that very distinct pattern we talked about, much more common in prepubertal children.
And you mentioned a specific demographic association there.
Yes, data suggests it's particularly prevalent in Afro-Caribbean children living in urban areas in the UK. That's a really high yield point for exams.
Okay, Tinea pedis, common adult adolescent. Tinea capitis, common prepubertal child, especially Afro-Caribbean urban UK. Got it. So When it does show up, what are the typical clinical features? What does tinea actually look like?
The general picture is usually red, scaly patches, and they're often quite itchy. If it's affecting hair, like Tinea capitis, you'll see hair loss. If it's nails, they might become brittle or discolored.
And that classic ring shape we mentioned.
That's the sort of textbook appearance for Tinea corporis, that expanding red edge with the clearing center. But, and this is important, it doesn't always look like a perfect ring. It can be more solid, irregular shapes, sometimes just subtle scaling. Don't rely solely on finding a perfect ring.
Which brings us back to why clinical diagnosis alone, especially for Tinea capitis, can be unreliable, as the notes highlighted.
Exactly right. Tinea capitis is notoriously varied. Clinical diagnosis by itself is just not reliable enough. You might see inflammation, scaling, patchy hair loss. Sometimes it's quite acute with lots of redness, even pustules forming.
And there was that specific sign, the black dot appearance.
Yes, that's a good one to know. What happens is the hairs infected with the fungus become brittle and break off right at the scalp surface, leaving these tiny black stubs visible in the hair follicles. It looks like little black dots scattered in the area of hair loss. It's quite characteristic for certain types of Tinea capitis.
Black dot, Tinea capitis fus, broken hairs at the scalp surface. That's a good visual.
It is. Also, remember the carrier state? Someone can have the fungus living on their scalp, shedding spores, able to transmit it, but have absolutely no symptoms themselves.
Symptomatic spreaders. Always makes things harder.
It does. And then there's the most severe presentation, the carrion. You need to recognize this.
Tell us about carrion.
A carrion is basically a significant inflammatory reaction to the Tinea capitis infection. It presents as a large, boggy, tender, often pus-filled lump or mass on the scalp.
Sounds nasty.
It is. It's often associated with swollen lymph nodes in the neck, sometimes fever or feeling generally unwell. And occasionally it can be followed by one of those widespread eye reaction rashes. A suspected carrion needs urgent attention and referral to dermatology.
Okay, carrion, severe, boggy, pus-filled inflammatory scalp mass reacting to tinea. Urgent referral needed. So Tinea capitis features: unreliable visually, scaling, hair loss, inflammation, maybe pustules, the black dot sign, possible carriers, and the severe carrion.
That pretty much covers the spectrum, and because it's so variable and mimics other things.
Investigations become really important.
Crucial. While you might strongly suspect tinea clinically, getting lab confirmation is vital if you're unsure, if it looks atypical, or if initial treatment isn't working. And for Tinea capitis, it's generally recommended anyway.
How do we get the samples for the lab?
You need either skin scrapings or hair samples from the affected area. For a skin lesion, you scrape the active, raised edge. For the scalp, you try to pluck some affected hairs, especially those black dots if you see them. Or you can use a sterile brush or even a toothbrush head swept across the scaly area to collect material.
The notes mentioned using special black cards.
Yeah, they can be helpful. The dark background makes it easier to see the fine scales and broken hairs you collect.
Okay, sample collected. What does the lab do?
Two main things: microscopy and culture. Microscopy involves looking at the sample under a microscope, usually after treating it with potassium hydroxide, KOH, to dissolve skin cells.
What does microscopy tell you?
It can rapidly confirm the presence of fungal elements, the hyphae or spores. You can often get a microscopy result relatively quickly, maybe within 24 hours. It tells you if fungus is there.
So quick yes/no on fungus.
Pretty much. Culture, on the other hand, involves trying to grow the fungus from the sample on special agar plates. This takes much longer, typically 2 to 3 weeks.
Why wait that long for culture then?
Because culture identifies the specific species of dermatophyte. And knowing the species can sometimes guide treatment, as different fungi can have slightly different sensitivities to antifungal drugs. It's especially important if the infection isn't responding as expected.
Ah, okay. Microscopy, is it fungus?
Quick.
Culture, which fungus exactly? Slow, but helps guide treatment if needed. That 2-3 week wait is important for managing expectations. Any tips for sending the samples?
Yes, definitely tell the lab if the patient is already using any antifungal treatments, topical or oral.
Why is that?
Because treatment can suppress fungal growth and potentially lead to a false negative culture result. Also, mention any animal contact or recent travel history. It can give clues about the likely fungal species.
Good practical points. What about how to store or transport the sample?
Really important one, this. Keep samples at room temperature. Do not put them in the fridge.
No fridge, why not?
Cold temperatures can inhibit or kill the fungus, meaning it won't grow in culture, giving you another false negative. Room temperature is best.
Room temp, no fridge for fungal samples. Got it burned in. Do we test again after treatment?
Sometimes, yes. Especially for Tinea capitis, repeat cultures might be done after the treatment course to confirm microbiological cure that the fungus has actually gone.
Okay, so investigations. Key for confirming Tinea capitis. Identifying the specific fungus if needed, checking for cure. Quick quiz then. A child has suspected Tinea capitis. You send scalp brushings. What's the first result you expect back, and what does it tell you?
First back would be microscopy, hopefully within about a day, telling you whether fungal elements are present or not.
Perfect. Right, let's move on to the bit everyone wants to know. Management. How do we treat Tinea capia?
Okay, the general principles involve antifungal medications. These can be topical creams, lotions, shampoos applied directly to the affected area or oral, taken as tablets or liquids. Good hygiene is also essential, keeping areas clean and dry, avoiding sharing items.
When do you use topical versus oral?
Topicals are often sufficient for localized, uncomplicated Tinea corporis, Tinea pedis, or Tinea cruis. Oral antifungals are usually needed for more widespread infections, severe cases, nail infections, Tinea unguium, or, crucially, for Tinea capitis.
Let's really focus on Tinea capitis management again, as it keeps coming up as high yield.
Yes, absolutely. First point, if you suspect a carrion, that big, boggy, inflammatory lump that needs urgent referral to dermatology, don't manage that solely in primary care initially.
Urgent referral for carrion, got it. What about standard Tinea capitis?
Most cases can be managed in primary care. Self-care advice is important. Gently softening any crusts to help treatment penetrate. Strict advice on not sharing hats, combs, pillows, towels. Also inspect close contacts, especially other kids in the house, and consider checking pets if animal contact is suspected.
And the core treatment for the scalp itself, topical or oral?
Oral. For Tinea capitis, oral antifungal treatment is essential. It's the cornerstone.
Why so definitively oral?
Because the fungus lives down inside the hair shaft. Topical creams and shampoos just don't penetrate deep enough into the hair follicle and shaft to eradicate the infection effectively.
Oral treatment is king for Tinea capitis because the fungus is inside the hair. Excellent memory hook.
Exactly. So you'll usually start oral treatment for both adults and children diagnosed with Tinea capitis, either clinically clear or confirmed by microscopy while awaiting culture.
Which oral drugs are typically used first line?
The main initial choices are usually crucifulvin or terbinafine. You start one of these, often for several weeks. The exact duration depends on the drug and the response.
Okay, crucifulvin or terbinafine. What if the culture comes back showing a fungus that's maybe less sensitive, or the patient isn't getting better?
Then you might need to consider switching to another oral agent, like itraconazole, based on those culture and sensitivity results.
Right. What about topical treatments for the scalp then? Are they completely pointless?
Not entirely useless, but they have a different role. Nice guidance suggests considering an antifungal shampoo like ketoconazole or selenium sulfide in addition to the oral therapy, usually for the first 2 weeks.
Why add the shampoo?
The main reason is to reduce fungal shedding and decrease the risk of transmission to others while the oral medication is starting to work. It helps with decontamination of the scalp surface, but it won't cure the infection on its own.
Okay, so topical shampoo reduces spread initially. Oral tablets provide the actual cure from within the hair. Smart combo. What if it's stubborn?
If the clinical signs seem better but follow-up tests still show fungus after the initial course, the guidance suggests continuing the oral treatment for potentially another month or so and reevaluating.
And what about those asymptomatic carriers? Do they need the full oral treatment course?
Generally, no. Carriers without active signs of infection usually don't require oral antifungals. Topical shampoos might be recommended for them to reduce spore load, but the focus is treating the active infections.
And what if you find a child contact of a case? Do you just treat them anyway?
No, you examine them carefully. Oral therapy is usually recommended for contacts only if infected hairs are confirmed, typically by microscopy or culture. You don't just treat all contacts prophylactically without proof of infection. That's important.
Okay, let's recap management. Urgent carrion referral. For capitis, oral treatment is key. Crucifulvin terbinafine first line. Add topical shampoo initially to cut transmission. Treat for several weeks, maybe longer if persistent. Carriers often just get topicals. Contacts only treated if infection is confirmed. Plus general hygiene. That's a solid plan.
Covers the core points for MSRA in practice, definitely.
So if treatment goes well, what's the usual outcome? Prognosis.
Generally, the prognosis for most Tinea infections is very good, assuming the right treatment is used. Most cases clear up completely, usually within a few weeks to months, depending on the site and severity.
But it can come back, can it?
Yes, recurrence is definitely possible, and that often happens if the underlying risk factors aren't sorted out. If someone keeps going back to the same damp gym environment without precautions, or keeps sharing towels, or if there's an unresolved immune issue, reinfection can easily occur.
So treat the infection, but also tackle the source or the risk factors to stop it coming back. Makes sense. Lastly, any nasty complications we need to worry about.
Thankfully, serious complications are not common with typical skin tinea, but they can happen, especially if it's left untreated, very extensive, or if the person is immunocompromised.
Like what kind of problems?
Well, the fungus damages the skin barrier, right? That can create an entry point for bacteria. So, secondary bacterial infection superimposed on the fungal infection is probably the most common complication.
Which could potentially lead to.
In some cases, it could progress to cellulitis, which is a deeper bacterial infection of the skin and soft tissues.
Well,
Also, chronic persistent inflammation from long-standing tinea can occur, although that's less frequent.
okay, so usually okay, but watch out for added bacterial infections, possibly leading to cellulitis, especially if neglected.
Exactly. So if symptoms suddenly worsen, like increasing pain, redness, warmth, swelling, or post-discharge, especially during treatment, you need to think about secondary bacterial infection and reassess.
Right, that's a comprehensive run-through. We've really done a deep dive on Tinea, aka ringworm. Key takeaways. It's fungal, caused by dermatophytes eating keratin. Spreads via contact and fomites. Risk factors include dampness, shared items, maybe low immunity. That's a red flag.
And for Tinea Capitis specifically, common in kids, especially certain demographics, variable presentation, watch for black dots, and the severe carrion.
Investigations using microscopy and culture are often vital, especially for scalp remember room temp for samples.
And management hinges on antifungals, with oral therapy being absolutely key for Tinea Capitis because the fungus is inside the hair. Add topical shampoo initially to reduce spread.
Prognosis is generally good, but address risk factors to prevent recurrence, and watch for secondary bacterial infection as a complication.
That really covers the high-yield essentials for tinea.
Hopefully that focus session helps all that sink in, whether it's for your exams or just day-to-day practice. For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.